Professor Shankar Hari, it's an honor again to have you in the ISCCM Vodcast.
Yep.
Our next question, the disease like sepsis and ARDS, especially sepsis, the heterogeneity is always an issue with the subjects involved. Especially when we are talking about the subtyping, the phenotyping of the subjects which have the diagnosis, and with regards to the precision treatment or personalized treatment for any disease, especially for the sepsis, because subtypes can share certain biology and it can affect outcome also. So we would like to listen from you. How clinically relevant are those phenotypes, especially with regards to improvement in diagnosis, treatment, and prognosis in sepsis? And that question is followed by what impact might these subtypes help us in tailoring our treatment to better outcome?
Yeah, so heterogeneity essentially means that you have a variation either in the risk of developing a disease or risk of having an outcome from the disease or risk of response to treatment with the disease. So that's essentially the basic premise of heterogeneity. And heterogeneity is not unique to sepsis and critical illness. It is there everywhere. It is there in myocardial infarction. It is there in COPD. It's there in asthma. That is fundamentally because of the fact that we all have evolved dealing with different environmental challenges. So therefore, the way our body responds to infection or any form of illness would be different. So that's the kind of the starting point for this notion of heterogeneity. Then comes the point about how does subtyping help? And as you rightly point out, the heterogeneity essentially means that whenever we do an idea of looking for a biomarker or a subtype of sepsis, depending upon the type of test you do or the measurements you do, you will have different phenotypes or subtypes. What do I mean by that? So if you think about, let's take for an argument's sake, you are going to take a clinical definition of a heterogeneity. And here, if you just take a blood sample, not a blood sample, just purely clinical data, then what you would essentially have is patients with variation in a particular organ system, like a blood pressure or a liver disease or a renal disease, and patients who are young and old, patients who are male and female, patients who got respiratory disease or non-respiratory disease, patients who got other illnesses. In other words, your subpopulation is determined by the nature of the data that goes in. The second feature of the terminology that is important here is a phenotype merely represents a cluster of visible properties in an organism. It does not mean anything more. Now, when people talk about subphenotype, they immediately think that you've kind of understood the biology. No, we haven't. And it is fairly obvious when you think about some of the subphenotypes of sepsis reported in the literature. For example, there are sepsis subphenotypes purely based on clinical data. And here there is no understanding of underpinning mechanism. Then there are subphenotypes based on transcriptomic data. And what you get there with the transcript-based subphenotyping is purely a two-dimensional reduction of variation in 36,000 parameters that you've studied. That's a very crude way of stating what you're seeing there. You get 2, 3, 4, whatever, depending upon the number of rules that you set and what variation you're looking for. So even within those subphenotypes, you only have a relative mechanism, as in subphenotype X has a different mechanism compared to subphenotype Y. There is nothing that is out there in the literature that says subphenotype X has got a unique sepsis-specific mechanism. I think that is an important point to think about when you don't have a good enough control to identify the subphenotype. So to kind of, instead of making this even longer, I'll just stop there so that you can ask other questions around it. What we currently have is a complete lack of true analysis of longitudinal multi-domain biological data to call a subphenotype of sepsis based on mechanism. What we do have is a lot of subtypes of sepsis based on either clinical parameters or one or more biological parameters that actually provide very little information on how to treat them. I think that is the fundamental problem we have. I would essentially say subtyping field is just starting to take shape, and anybody who thinks that they have found a subtype to treat using the basic premise of precision medicine is actually not saying the complete truth.
Very well said, and we agree with that particular point you raised very clearly regarding the heterogeneity and phenotyping in sepsis.
Thank you.